Well, good afternoon for those of you on the East Coast, and I appreciate everyone staying with us for this final portion of day one of the Focused Ultrasound Glioblastoma workshop. So today I'm joined by a group of really thought leaders in the field of focused ultrasound and specifically also in the field of sonodynamic therapy. Dr. Prada, Dr. Liu, and Dr. Hynynen are here to discuss and share their insights in sonodynamic therapy. It's something that's near and dear to my heart as well, as we've been working closely with Dr. Prada and some of the experiments, and I've had the opportunities to read some of the work by our other two discussants as well, and we've actually been able to help to be guided in our experiments with some of the work that has been coming out of their labs. But let me start off by asking Kullervo a little bit about his thoughts about the aspects of sonodynamic therapy and as a option for treating glioblastoma, and particularly what he may be most excited about in terms of sonosensitizing agents.
So I don't know too much about since we have used only one, but it looks very, very promising. So I was really surprised. We collaborated with Dr. Marcus. He was the one who got me interested in it. And we were looking what the mechanism might be. And at the end result, we had the animal results were very, very, very promising. So I think it may be, in my mind, maybe one of the most promising techniques when we use focused ultrasound for glioblastoma.
And you alluded to the fact that about mechanisms of sonodynamic therapy, and that's something that we've been investigating, but I think you've hit the nail on the head that those mechanisms are not fully defined. But if you could share your thoughts a little bit for the audience about what you see as the important underlying mechanisms of sonodynamic therapy and how those might be exploited in a tumoricidal effect way to augment the effects of this treatment on glioblastoma.
So when I looked at acoustic parameters from the Chinese study, I thought that it is maybe thermal effect, just 1 or 2 degree temperature elevation in the brain, which would be very easy to induce in the brain. So it would be useful even if it was thermal effect. But then when we did the actual measurements, it turned out that I don't think it can be explained by temperature. So the second theory that people have had is that it's bubble effect. The intensities are very, very small for initiating inertial cavitation. So I think what we think now is that there are some bubbles in the tissue that are collapsing, maybe, but very few, and those are causing the mechanism. But I'm not sure. I don't think there is a definite evidence yet what the mechanism is. How we might think differently, I don't know.
Francesco, turning to you on that, on your enthusiasm about different sonosensitizing agents. First of all, what are your thoughts on what may be some of the more promising ones for glioblastoma at this point?
Oh, thank you for your question. In my hospital, we developed the use of fluorescent for surgical guidance. And we noticed that fluorescent is able to highlight and selectively accumulates in different histotypes, such as metastasis, meningioma. And at UVA, we did some experiment with fluorescent in glioma, and it does have an effect for sure. So it might be, should be cautious because it's not as selective as 5LA, but it could be a promising agent for other histotypes of brain tumors. And one of the advantages over other sensitizers is that fluorescent is also approved. Its use is approved in a clinical setting, so we can go to the clinical realm faster than with other sensitizers.
And how about your thoughts on underlying mechanisms that can be exploited for, with sonodynamic therapy? I know you've done a little bit of work on that.
I'm fascinated by the idea that is explained in the presentation from Stuart Marcus about the sound, which is able to generate lights in the depth of the tissues, and then this allows to activate the sound sensitizer. I think also that there is a mechanical stimulation of the immune system and probably a vascular effect. So it's not only activation of the sensitizer, but there is also a mechanical. We did some in vitro studies, and we were able to unmask the glioblastoma antigens even without the sensitizer. So I think that there is more than one mechanism in play.
Mm-hmm. Excellent points. Dr. Liu, I know you've done very elegant work on this concept, and obviously your work with Navifus has needs no real introductions. The idea of using this type of approach, though, how discrete do you think, we've talked about discrete targeting and use of MRI-guided FUS versus neuronavigation-guided FUS, because of the selectivity of the sonosensitizers to the target tissues, in this case, brain tumors and specifically glioblastoma. Are we worried so much about the exquisite precision and accuracy that may be required for SDT in either preclinical animal models of glioblastoma or in clinical trials? What are your thoughts?
I think, thank you for your questions. I think right now, people think the MR-guided focused ultrasound has the most accurate possibility to treat the brain tumors. But also we proved that using the neuronavigation guided focused ultrasound also can push the accuracy within acceptable ranges. So because of the feasibility of the neuronavigation, so it may be put some advantages, particularly is easy to use and very suitable for the outpatient treatment. So I think Navifus has a niche when apply the Navifus to apply the brain tumor treatment.
Mm-hmm. I mean, in many instances when we're treating, and it's been brought up in other discussions, when we're treating brain tumors with precise approaches, LINAC-based radiotherapy, stereotactic radiotherapy, radiosurgery, frame-based or frameless-based, or even MRI-guided procedures, such as some of the LINACs that are now available, we do consider and even putting a little bit of a margin on the tissue. So one wonders how much, in the setting of glioblastoma, how much of a really discrete targeting we need versus something that maybe has a little bit of a margin. For instance, it's not uncommon in some of the brain tumor clinical trials that we would do with radiosurgery to add a 2 to 3 millimeter expansion of the target volume of what's considered the gross tumor volume, and then add an expansion. Do you think that something analogous like that might be capitalized with sonodynamic therapy? How precise do you think we need to be, I guess, is sort of what I'm circling back to.
I think that the concept should be pretty similar to the blood-brain barrier opening. For blood-brain barrier opening, for drug delivery, the neurosurgeons always want to leave margins to cover the peripheral regions because some tumor seeds already infiltrate in those regions. So the neurosurgeons, typically they want to deliver more drugs and cover those peripheral regions. So I believe that for the SDT treatments, the pretty similar concept, we need to leave a margin to deliver those or activate these sonodynamic sonodynamic agents to live in these peripheral regions.
Right. No, and I completely agree with you on those concepts. It's not uncommon, as we do a radiation therapy plan for glioblastoma and giving a concentration of dose to what's the gross tumor volume, the enhancement, but then adding a margin that's oftentimes compensating for the T2 enhancement or the flare signal changes that occur. When we know that typically recurrence of a glioblastoma is going to be within 2 centimeters of that margin of the enhancing tissue. So that 2 centimeter margin is not, it actually has fairly consequential tumor burden at times. I could ask you gentlemen questions all the time, but we have some questions from the audience. Here's one. Karen, maybe you can answer this or provide your insights, and we'll go down the road. What cell death pathways are activated by sonodynamic therapy, and could we leverage this knowledge for combination therapies? Maybe SDT and BBB opening, or SDT and mild hyperthermia that would radiosensitize. What are your thoughts?
Yeah, no, I'm not an expert in the pathways, but yeah, I think combination might be good. The beauty, of course, this is that the agent targets the cells, so you could go fairly wide in the brain to treat, and the exposures are so low that they are not causing any damage on normal brain tissue. So you could combine it with any kind of therapy in that sense.
Do you see the parameters for focused ultrasound with SDT being most analogous with any other modalities that we would want to exploit? In other words, is SDT, focused ultrasound parameters, the frequency, the power, analogous to one of these other approaches we've talked about earlier today?
Yeah, no, I mean, it is low. You don't use bubbles, but it's a similar magnitude with bubbles when you open the blood-brain barrier, at least in our experiments. So you could, it's a similar device, same kind of device can do it and doesn't require high power, so no need for ablation. So.
Wonderful. Francesco, any thoughts on the SDT therapy pathways and exploitation with combination approaches?
I'm not an expert either about pathways. For sure, one of the phenomena that occurs is that the cells undergo apoptosis. It's not clear when this phenomenon starts, so probably more preclinical studies with different time points would be very helpful. I would add about the safety of something about the safety of sonodynamic therapy, if I may. As you are aware, we conducted a safety study on the sonicating the normal brain in pigs. This is a study that is going to be published soon. And using 5LA and fluorescent at a clinical dosage and sonicating the normal brain, we didn't observe any damage. So, because as Dr. Hynynen pointed out, the parameters we use are very low. There is no mechanical damage nor accumulation of the sensitizer. Therefore, no damage to the normal brain.
Yeah, I see Dr. Marcus has joined us too. Dr. Marcus, thanks for joining. Dr. Marcus is integrally involved with Sono ALA since. Can you hear me, Dr. Marcus?
Yes, I can. Can you hear me?
Wonderful. Yes. Thanks for joining. I wonder if you might comment a little bit upon the safety of sonodynamic therapy, but also what data you have in this regard, and then where you see sonodynamic therapy potentially being leveraged with combination approaches with either other types of focused ultrasound modalities as we've discussed earlier today, or the adjuvant therapy options that are currently used for glioblastoma.
I'll be happy to. I think one of the things, I've been working with ALA and photodynamic therapy for almost 30 years. And one of the things we have to remember that protoporphyrin accumulation in glioblastoma has the positive, fluorescence has a positive predictive value of 98%. And therefore, it is the most selective biomarker in clinical history. And therefore, work has been done in photodynamic therapy in glioblastoma by Professor Stuart. And unfortunately, because it's so complex, his is really the only laboratory that's reported on it. But photodynamic therapy with glioblastoma can actually, a single treatment can result in follow-up and a lack of recurrences in a handful of patients that took 3 years. So my feeling is that if we adequately provide parameters for sonication and SDT, it's really photodynamic therapy because we're producing sonoluminescence and generating light and photons in a spectrum that actually is ideal for activating protoporphyrin. So my feeling is we can, and we hope to show this in our own development work and the work that Dr. Sanaya is doing, we can actually treat and produce apoptosis in the non-contrast areas of the GBM and produce apoptosis in that region. It's generally, I feel that this is really a future treatment paradigm, which is going to be the safest and probably the most effective for glioblastoma that we've seen since temozolomide. And I make that prediction here.
Well, coming from you, that carries a tremendous amount of weight. And tell me a little bit about the time frame that you think some of these downstream cascading events are occurring with SDT or with a photodynamic process. When are you seeing apoptosis in glioblastoma in these experiments you've done? What's the time frame from activation, if you will?
The activation is immediate. As soon as you produce photons in the brain, in the cell, the protoporphyrin is on the cell membrane and the mitochondrial membrane. The cell membrane will produce lipoperoxidation, blowing open cells, holes in the cell membrane.
I think we may be losing you there. Dr. Liu, if you will, can you talk a little bit about your time points for experiments you've done with Navifus and SDT, either in preclinical or clinical settings? When, from the delivery of the ultrasound and with a sonosensitizer, when are you seeing some of the downstream effects of actual tumoricidal changes, be it apoptotic or otherwise? What are your thoughts? How quickly is this occurring?
Yeah, previously we have tested let the cell uptake 3 hours, or we choose to let the cell uptake 24 hours, but we've seen the effect is pretty similar. So we do not have further information, but we think there's a wide range to design the ultrasound parameters. The time point should be arranged. Yeah.
And do you have any sense about the optimal ultrasound parameters that would be used to augment the effects of either 5-ALA mediated sonodynamic therapy or rhodamine sonodynamic therapy or other types of sonodynamic therapy?
Yeah, so according to the literature, we saw some papers, they use a continuous wave, and some papers, they are using the pulse wave. So the parameters are also very versatile. And also the paper described there's a little correlations with the pressure level. So it means that the lower pressure level can still induce the cell toxicity, and higher level can also do the same one. So just recall the other two panelists. So far, we do not clearly know what is the mechanisms. Is a cavitation? I think is a thermal effect. So far, nobody 100% sure.
Well, I think there are a lot of opportunities, as alluded by Dr. Marcus, even as a photodynamic approach as well. Question from the audience about Dr. Marcus, I think, is back on, but this is really for anyone in the audience. Dr. Marcus, you may have some specific thoughts on this. How is IV 5-ALA different And I'm not sure if anyone's explored that, but do you have any thoughts, Dr. Marcus? Can you hear us now? You may be muted.
Of course.
There you go.
Yes, oral ALA produces nausea and vomiting and an increase in liver function tests, which is kind of routine, and also generally lower blood pressure. Because there is a up to 40% first pass effect with the liver, you also get an increase in liver function tests. So certain patients with hepatic abnormalities, it may be difficult to use it, and they may have abnormal liver function tests. Intravenously, you bypass the liver completely, and you also bypass the stomach, so you don't get the nausea, vomiting, and you get a much more efficient delivery of ALA to the tumor.
Mm-hmm. So potentially a means of not only delivering a sonosensitizer more efficiently, but also avoiding some of the downstream side effects of that with an oral intake. I'll talk a little bit. I think we've been given a couple more minutes here. Just thoughts on the use of sonodynamic therapy for other types of tumors besides glioblastoma. One of the things that's fascinating me too is that 5LA, and Dr. Stumer, you mentioned him, obviously a legend in the field of 5LA, and having done some exquisite work. We were pleased with the Journal of Neuro-oncology to have Dr. Stumer and Kostas Hadjipajani put together a special issue on 5LA for brain tumor surgeries. But there's 5LA also has a nice sequestration in other types of tumors, meningiomas and brain metastasis. Have any of you explored the effects of sonodynamic therapy in non-glioma brain tumors that may be recurrent? Dr. Marcus, you probably have experience.
I want to quickly answer that. Number one, Sonodynamic is working with Dr. Roger Packer, and we're going to be doing a study on him on diffuse intrinsic pontine glioma, children with that horrible disease. We feel the safety and efficacy of ALA sonodynamic therapy is so good. And we've also worked with the Children's Hospital in Zurich, pediatric DIPG laboratory. Javed Nazarian and his group are showing that DIPG tissue cultures take up ALA and produce protoporphyrin at a rate even higher than C6 rat glioma cells. So we're very excited about moving forward with DIPG, and I believe it will work in others as well.
Guillermo or Dr. Liu, have you had any experience with sonodynamic therapy for other types of non-glioma, or at least non-glioblastoma targets?
We haven't. We have just on brains.
And Dr. Liu, you've not either?
No.
We've had a chance to explore a little bit of its effects in melanoma, and 5LA is taken up in almost 75% of metastatic cancers of certain types, including melanoma. So there may be some opportunities to exploit in some ways or translate some of the wins that may be realized in glioblastoma and DIPG into other metastatic disease. Dr. Marcus?
Sonodynamic has a clinical trial on the books on our program to treat tumors metastatic to the brain, which of course would include melanoma and lung cancer and other cancers as well. So yes, you're quite prescient. We intend to treat that, and we believe we will get excellent results with sonodynamic therapy and metastatic melanoma to the brain.
Well, we'll have to open that one up at my institution. Be sure to have someone contact me. I'd be eager to see that.
You got it. You got it.
Francesco, your thoughts on next steps? I know you've got a trial that's opening up in Italy and not in the not too distant future. I think it's been approved. Tell us a little bit about that trial.
Yeah, it's a safety and feasibility trial. So we're going to do sonodynamic therapy using the Insightec MR guided system up front before tumor resection. So we're going to sonicate the tumor, follow the patient with a series of MRI scans, and then take out the tumor and perform a histology to see what happens, and then use a control group to compare it. But the first endpoint, the primary endpoint, is the safety. Hopefully, we'll start by the summer.
Wonderful, exciting. And I think it's important for the audience to hear that although we're talking about at times, cellular models and preclinical models, that as Dr. Marcus and Dr. Prada have already indicated, that there are some early phase clinical trials that are underway with sonodynamic therapy that are really promising. Dr. Liu and Dr. Hynynen, do either of you have early phase clinical trials that might be coming in the near future at your sites for using this type of approach or looking at this?
So we don't have currently, but most likely we'll start sooner, but not at the moment.
And will you, Kirma, will you be trying to target glioblastoma for the most part, or would you? Yeah,
well, that might be the first target, yeah.
And Dr. Liu, tell us a little bit about any likely early phase clinical trials that might be open looking at SDT, as it is in so many ways using a relatively low power ultrasound and using in many instances probes that are already approved for use for other purposes within brain and as well as other medical indications.
Because the parameters are pretty similar to the blood-brain barrier opening. So it's quite helpful that we can use the same machine to trigger the sonodynamic effect. So we are preparing the clinical trial in Taiwan now, and hopefully we wish the clinical trial can launch soon.
Well, it'd be wonderful to have to reconvene maybe in person sometime in the 2022 with the group of outstanding discussions here and see where the clinical trials are and where the preclinical science has led us with sonodynamic therapy. As is true with so many of the other modalities that we've discussed, I think there's tremendous promise for a disease state, glioblastoma, that requires so much more work to improve the outcomes. So with that, I think we'll conclude. And Susie, you were going to have some concluding words for day one of the session and maybe set up the stage for day two. Thank you all for joining on the discussion.
Thank you, Jason, and to the panelists for that incredibly inspiring discussion on sonodynamic therapy. And I hope everyone really enjoyed the entire day. It was fascinating, filled with great discussions. I want to specifically thank all the moderators and the panelists for sharing their expertise and their perspectives. I also want to thank the AV company, Jason and Charles, as well as everyone behind the scenes at the Focused Ultrasound Foundation, especially Lauren, for making this day possible and just work seamlessly. I thought it was fantastic. Tomorrow, we have a really exciting lineup, so make sure your calendar is free. We're going to be discussing technology, patient selections, treatment monitoring, and clinical trial designs. And then most importantly, at 1:08, make sure 1:08 to 2:08, you leave that hour free to participate in our roadmap discussion. And it's really important because the reason, for example, that sonodynamic therapy is so exciting is that we were able to translate the preclinical work into clinical trials. And so we need your help in making sure that we can take all of these other fascinating ideas from the preclinical realm into the clinical realm and beyond. So we want to use your knowledge tomorrow and have interesting discussions on creating that roadmap. So I hope to see you all tomorrow, and then I hope you can all stay for the roadmap. So have a great afternoon, evening, and thank you again for coming.